Welcome to Session 2. In this presentation, we will discuss steps to solving a medical coding exam case study. But first, I want to introduce you to the team. First up, Mr. Sandeep. Mr. Sandeep coming to you live from Abu Dhabi. He is an AMCI co-lead instructor. Next up, Miss Eva coming to you live from the state of Florida. She's also a co-lead instructor and the intern coordinator. And finally, myself, Mrs. J. I'm the curriculum director at AMCI. Now, let's meet the AMCI interns. We have Miss Anubama, followed by Miss Carla, Miss Courtney, Miss Dolly, Miss Vivian, and Miss Melissa. And the goals of the presentation are to review integumentary, musculoskeletal, and respiratory scenarios. Now let's talk about how to solve a multiple choice case study scenario the AMCI way for the board exam. This is how we do it. We teach you to highlight your key terms, and this key on the right tells you the colors that you should use and for what. A yellow highlighter should be used for diagnoses, all diagnoses, signs, and symptoms. The green will be for procedures. So if you have a green highlighter, the green will be used to highlight only procedures. And pink, these are inclusive or bundled items. All right? Once you've done your highlighting, you're going to have to document your inventory. That's your procedures, diagnoses, and select a primary code. Which diagnosis is primary, which procedure is primary. Then you're going to review all pertinent guidelines. And finally, the code that best matches your inventory list is often the correct code, or a code that is pertinent to a guideline. That will be your best code. All right. So here are some do nots. When you're highlighting, you can kind of get discombobulated. So we've compiled some things that you don't even have to highlight. Number 1, don't highlight things observed by the physician because you cannot code for them. Number 2, don't highlight closures. If a provider or surgeon is closing up a surgical site, there's no need to highlight it. However, if it involves a skin procedure or skin defect closure, you may definitely have to code that. So if it's closing a surgical site other than skin defects or wounds or lesions, you do not code it or highlight it. Also, you don't highlight bleed control, hemostasis, because that's pretty customary and it's bundled into the procedure code. You don't highlight drains, irrigation of the surgical site. Nope. And you don't highlight installation and removal of clamps and trocars because these are used to open up or maintain the surgical or operative site so the physician can view what they're doing, particularly if it's an open procedure. Also, you don't highlight dressings. And finally, you do not highlight surgical risks. Now that we've gotten that out of the way, I think you're ready to get started, and I'm going to hand it over to Mr. Sandeep. All right, Mr. Sandeep, take it away.
Risk. Okay, now let's move on to the first scenario, and the first chapter code is it will be integumentary. And I would like Miss Anu to come on the floor and help us in reading out this scenario. And meanwhile, I will be in the chats.
Hello, coders. Good evening, all. I'm just going to read this scenario. Here are the answers. A 19316 50, N 64.82, and B 19328 modular 50, N 64.82, and C 1932550, N 64.82, and the D is 1934050, N 64.82. The scenario is preoperative diagnosis, hypoplasia of the breast. Postoperative diagnosis, hypoplasia of the breast. Operative procedure, bilateral augmentation mammoplasty. Anesthesia, general. Operative summary. The patient was brought to the operating room awake and placed in a supine position where general anesthesia was induced without any complication. The patient's chest was prepped and draped in the usual sterile fashion. The patient had previous inframammary crease incisions on both the left and right sides. The extent of the dissection would be to the sternal border within 2 finger breadths of the clavicle and slightly beyond the anterior axillary line. The left breast was operated upon first. An incision was made in the inframammary crease growing through skin subcutaneous tissue down to the muscle fascia. Dissection at the subglandular level was then performed until an adequate pocket was made according to the previous limits. After irrigation with normal saline and careful hemostasis, a mentor and allergen silicone filled, high profile textured implant was used and placed into the pocket. It was 300 cc. The skin was closed using 4O Vicryl in an interrupted fashion for the deep subcutaneous tissue. 4O monocryl in an interrupted fashion was used for the superficial subcutaneous tissue, and the skin was closed using 4O monocryl in a subcuticular fashion. Antibiotic ointment and tehoderm was applied. The right breast was operated on in a very similar fashion. The implant was an 340 cc silicone gel, high profile, textured implant from allergen. Skin closure was the same. Both left and right breast were very similar in size and shape. The patient had a bra applied. The patient tolerated this procedure well and they left operating room in stable condition. Coders, here is the time starts now.
And I think that's 2.5 minutes. And coders, from what I see in the chat, what an amazing way to start the first scenario of this week one group study sessions. I did saw a lot of answers popping up before Miss Anu completed the session. It's great to see that. And thank you, Miss Anu, for reading out the scenario for us. So coders, if you haven't still figured out, you can continue and work on the answers. In meanwhile, we'll go ahead and solve the scenario. So the first step, coders, always let's highlight the keywords. You can see the pre-operative and post-operative diagnosis are the same. So we will always take the post-operative diagnosis. It is hypoplasia of the breast in this case, and the operating and the procedure performed is a bilateral augmentation mammoplasty. The patient was placed in a supine position with a general anesthesia given. The left breast was first operated. The dissections at the subglandular level was then performed. Adequate pockets was made. High profile textured implant was used and placed into the pockets. The skin was closed. Right breast was operated in in a similar fashion as well. The implant was a 340 cc silicone gel. And the correct answer to this question is option C, as many of you have said. Yes. So this is how we solve the scenario. The procedure inventory, we are having a bilateral augmentation mammoplasty. And in the diagnosis inventory, we are having hypoplasia of the breast. So coders, what's a breast hypoplasia? Breast hypoplasia is actually development of inadequate breast tissues to meet an individual's expectation of an adequate or a desirable breast. So commonly done procedure for this hypoplasia of the breast is breast augmentation, which is performed in our scenario. Uh, this is also known as augmentation mammoplasty. It is a surgery to increase the breast size, and this involves actually a placement of breast implant under the breast tissues or chest muscles. You can see in the diagram different techniques, methods used, like a dual plane insertion, subglandular insertion, and submuscular insertion of the breast implant. So this is just for your information, and let's come back to the coding portion and let's solve the scenario. Let's look in the first option, 19316, the 50 modifier. And 19316 is actually coding for a mastopexy. The mastopexy is actually also known as a breast lift. It refers to the reduction of the skin with the removal or a reduction of the underlying breast muscles to reorient the breast to a higher position. The mastopexy was not the procedure performed in our scenario. We performed a bilateral augmentation mammoplasty. Straight away, it's a wrong answer. Now let's look into 19328. It is coding for removal of intact breast implant. As the code language suggests, this is coding for removal of a breast implant. And once again, this is not matching our procedure inventory. That is a wrong answer. We eliminated option B as well. Now let's look into option D. That is coding for insertion of breast implant on the same day of mastectomy. And in the brackets, you can see it is written as an immediate. So this is a code for a mastectomy plus a breast implant placement. It is usually performed for the patients who has just undergone like a mastectomy procedure, which is removal of the breast, and then they will replace or place an implant, mostly due to some medical issues, medical health conditions. And this was also not performed. Mastectomy was not performed for our scenario. It was a mammoplasty that is performed, which eliminates option D and brings us to the correct answer, option C, 19325, which, as the code language states, is a breast augmentation with implant. How are you feeling about the first scenario, coders? Great, good way, great, amazing way to start. A round of applause to each and every one of you. Great work. It was a good scenario. Okay, now let's move on, coders. Let's move on to the second scenario for the day. And I would like to call Miss Carla up on the floor to read out the scenario for us. Miss Carla, it's all yours.
Okay. Answer A, 12051 11642, modifier 51, 85.8. Answer B, 12052 1142 11442, modifier 51, L85.8. Answer C, 11442, L85.8. And answer D, 12052 11422, modifier 58, L85.8. Preoperative diagnosis: rapidly enlarging suspicious lesion on patient's right side of forehead. Post Postoperative diagnosis: rapidly enlarging suspicious lesion on patient's right side of forehead. Operation performed: wide local excision with intermediate closure of the left right side of forehead. Indication: the patient is a 70-year-old white male who noticed within the last month or so a rapidly enlarging side of his forehead. Description of procedure: the patient was placed in the supine position on the table and was given no sedation. The area had the and the area his right forehead was draped and prepped with betadine paint in normal sterile fashion. The area to be excised was on the right side of the patient's mid-forehead. The lesion had a maximum diameter of 1.1 centimeter with a 0.3 centimeter margin designed for total resection of 1.7 centimeter. The area of excision was infiltrated with 1% lidocaine with epinephrine. Careful dissection of the lesion was carried down through the dermis into the subcutaneous tissues. After waiting for hemostasis, it was excised, tagged, and irrigated. Several bleeders were cauterized. The defect was closed in multiple layers with 3.0 Vicryl, 3-0 Vicryl, a running subcuticular stitch of 4-0 Vicryl, and a few 5-0 chromics. The total length of this closure was 3 centimeter. This was covered with sterile strips, adapted gauze, and tape. Patient tolerated this procedure with no complication and was sent home in stable condition. Final diagnosis: skin, right forehead, wide local excision, keratocanthoma, possible squamous cell carcinoma. Margins are free of tumor. What CPT and ICD-10 codes are reported? All right, coders, you have 2.5 minutes and your time starts now. Let's get it. Let's code. All right, Mr. Sandeep, that's time. I see a bit of an alphabet soup, so we're going to have some aha moments this evening.
Yes, Miss Carla, thank you. Thanks a lot. I do see a lot of alphabet mix as well. Okay. So let's move on, coders, and I'm sure you must be still working. Some of you must be still working on it, as I said. Please continue and put your answers in the chat. And meanwhile, we will solve the scenario. Let's highlight the keywords. Step one. You can see in this scenario as well the pre-operative as well as the post-operative diagnosis both being the same. Taking the post-operative diagnosis, rapidly enlarging suspicious lesion on patient's right forehead. The procedure performed is a local excision with intermediate closure of the right side of forehead. Suspicious lesion on the right side of forehead is indication. The patient was placed in a supine position. No sedation was given. Area to be excised was on the right side of the patient's mid forehead. The diameter of the excision is 1.1 centimeter with a 0.3 centimeter margin, designed for total resection of 1.7 centimeter. Dissection of the lesions was carried through the dermis into the subcutaneous tissues. The defects was closed in multiple layers, and the total length of this closure was 3 centimeter. And the final diagnosis, we have keratoacanthoma. So the correct answer to this question is option B. Option B, yes. I was going through the chats. Yes. Okay, let's go ahead to the next step. Step 2, getting your procedure inventories and the diagnosis inventory. In procedure inventory, we are having 2 procedures performed for this scenario. One is an excision of the lesion of the forehead, which was further found out to be a keratoacanthoma, and the excised diameter was around 1.7 centimeter in total. And the second procedure performed is the intermediate closure of the defect, which was around 3 centimeter. And the diagnosis, we are having keratoacanthoma and possible squamous cell carcinoma. And you must all know that we won't be coding other possible squamous cell carcinoma because it's a possible condition, it's not a confirmed condition. And towards the left side, you can see a image, a diagram, which you must all be familiar with by this time. You must have seen this in the CPT book under the excision procedures, excision of the lesions section. So this actually helps us to get the excised diameter of a lesion. So the excised diameter will be the length, the diameter of the lesion plus the margins. So doctors won't be just cutting out the exact diameter of the lesion. They will be leaving out certain margins on the either side. So the sum of the margins with the excised diameter is the total excised diameter of the lesions which we are having now. In our scenario, the margins was 0.3 centimeter on the each side. Let me move on to the next. Yes, we are having 0.3 centimeters of the margins on the each side with an excised diameter of 1.1 centimeter. So total excised diameter will be 1.7 centimeter. Okay, and these are our code options. I've done some churning as well to this, which will help us. Churning is going to really help us in solving such case scenarios. It saves a lot of time. So we are having the code series 11640 to 11642, coding for excision of a malignant lesion in the location of face, ears, eyelids, nose, and lips. And we have code series from 114 442 coding for excision of a benign lesion of face, ears, eyelids, nose, lips, and the code series 11420 to 11422 coding for excision of benign lesions of scalp, neck, hand, feet, genitalia, and intermediate repair of face, ears, eyelids, and nose and lips coding for 12051 to 12052. And let's bring up the FTR as well for the excision procedures. And I'm sure you must have listened to the study, like the part 3 classes where in the excision portions it must have said like the code series starting from 116 actually codes for excision of malignant lesion, and the code series starting with 114 series starts codes for excision of the benign lesion. So if you remember that, straight away you can see that keratoacanthoma being a benign lesion, we can eliminate any codes in this 4 option having 116 series, starting with 116 series. So I can see that in option A. So if I remember that point, I will be straight away eliminating option A. Another way is to go through the codes. Let's look into option A. It is coding for repair intermediate wound of the face, ears, eyelids, nose, lips of 2.5 centimeter less. And you can cross check with the procedure inventory we are having. We are having an intermediate repair of 3 centimeter. So it is going to be greater than 2.5 centimeter. And let's look into the next code option A is having, which is excision of malignant lesions of 1.1 to 2 centimeter at the location of face, ears, eyelids, nose, and lips. Once again, as I said, keratoacanthoma being a benign lesion, it is not an excision of a malignant lesion. So we can eliminate option A. How are you feeling, coders, so far? Are you following? Okay, let's move along. Now let's look into the option D, why it is wrong. 12052, which is coding for intermediate repair of the wound on the face, ears, eyelids, nose, lips of 2.6 centimeter to 5 centimeter. That portion is correct. We are having an intermediate repair closure of 3 centimeters, so 12052 is the one exactly fits it. And now let's look into the second code 11422, which is coding for excision of benign lesion of scalp, neck, hands, feet, genitalia. SI centimeter will be 1.1 to 2 centimeter. The location is a wrong one in this one, coders. We are having excision of lesions performed on the forehead. In that way, we can eliminate option D as well. Now let's have a look into the option C, why it is wrong. 11442, which is coding for excision of lesions of face, ears, eyelids, nose, lips, and the centimeter will be 1.1 to 2 centimeter. And this one is also a correct one, but there is a problem with option C, that is, it is not coding for an intermediate repair. And if you look into the FTR, it states that simple closures are the only one that is bundled to the excisions. We had an intermediate repair. So if you are having any repair other than simple repair along with excision, we must code them separately. Since option C is not having intermediate repair coded, that will go as a wrong answer as well. And the correct answer, option B, 12052, which is coding for an intermediate repair of the face, ears, eyelids, nose, lips of 2.6 centimeter to 5 centimeter, and 11442, which is coding for excision of benign lesions in the face, ears, eyelids, nose, lips with an excision diameter of 1.1 to 2 centimeter is the correct one. And how was this scenario? Wasn't it pretty little bit harder than last one. Yes, hard. Yes, but if you have done your procedure, if you have got your procedure inventories correct, it's easy to crack this scenario. You can just cross check with the procedure inventory the code options which you are having, and cross checking with the procedure inventory you can eliminate the wrong one. And as I said, churning also saves a lot of time.
Thank you, Mr. Sandeep, for those AMCI amazing and awesome explanations. Miss Eva, for being the orchestrator and conductor of the best interns on the planet. Yes, I said it. Miss Melissa, Anubama, Courtney, Carla, let's get it, let's code, Dolly, and Miss Vivian. And let's not forget our interns in the chat, led by Miss Biji. And you, the students, you all are simply the best, and we appreciate you. And we will see you next time for more great scenarios. You don't want to miss it. And thank you for participating in the AMCI Medical Coding course. Until next time.